This conference will now be recorded.
Okay, welcome everyone. Good evening. Welcome to AnCan's virtual chat support group for low and intermediate risk prostate cancer for Monday, February 9th, 2026. Welcome to both our first time and returning guests. I am your moderator for this evening, Stuart Jordan, and I'll be assisted by Bill Franklin and AnCan's founder, Rick Davis, and Boykin Jordan, no relation, who should be arriving in a little while. We would like to note that this is a peer-to-peer support group and should not be construed as medical advice. We're here to share our collective experience and answer questions, and we hope that will provide information that we encourage you to discuss with your doctors. I will make a note that if there are any doctors as part of the group, that's because they are also patients and they are here in their personal, not in their professional activity. Before we begin this evening, AnCan would like to thank our sponsors for all of our prostate cancer support groups. They are Novartis, Telix, Blue Earth Diagnostics, and Foundation Medicine, as well as our participating base. We would like to, if you'd like to support AnCan, please visit our website. At AnCan, we have multiple prostate cancer groups for our attendees. We have groups that focuses on active surveillance for those who are considering or have opted to postpone treatment. Tonight's group addresses low and intermediate risk that are planning or have had treatment. As a note, please be aware that we do not address recurrence in this group and instead invite those people to join our high risk recurrent and advanced prostate group, which meets tomorrow night in this same room. We also have special groups for veterans, men under 60, gay and bi men, and starting this month, a new group for European men that will be open to all levels. Information about all of these groups are on the website, ancan.org/prostate cancer. There was something else I was in my head, but it went out. So the way we work is we like to welcome and start with our new members, our new visitors, and get a chance to get to know them, hear their story, and see how we can help. And after that, we will go through the rest of the folks who are looking for some time. So with that, Bob Richards from Augusta, welcome. And the way we work, Bob, is we have a short list of questions that we'd like to go through so that we get some basics on you and your case, and then we'll want to hear from you as to what your questions and how we can help you. Bob, how old are you?
67.
I'm sorry, was that 6, 7?
67, yes.
Okay, great. And we know where you live. Are you a veteran?
I'm not.
Okay. And how did you hear about us?
I heard about you through a friend of a friend.
Okay, great. We love to hear that. And that was it. Are you signed up yet, Bob, to get our email reminders about the group?
I'm not.
When we, okay, if you would like to do that,
Sure.
if you want to pop your email in the chat, we will take care of making sure you get signed up so you get the reminders about when we're meeting. So, so now we want to hear your story. And so the first question is, when were you first diagnosed and how did that come about?
Well, I was diagnosed recently, so I had a biopsy in December.
Okay, what happened?
I-
Just take a step back before the
let me,
biopsy.
yeah, let me take you a step back. So I'm 67, no history of prostate cancer in my family. I've got a brother a year and a half younger than I am, and a very active 94-year-old dad. I have been on testosterone therapy for about 10 years. Um, Not that I really needed it. I naturally have a little bit of a low count, but it just makes me feel good. And used to have some good supervision, but sort of got away from that. In 2022, my PSA was a 2.7. And unfortunately, I changed. Anyway, I took my eye off the ball. Did not test in 23, did not test in 24. In February of 25, I tested at a 5.4. So I immediately stopped testosterone therapy and was searching for what was next. My PSA is now somewhere, it varies, anywhere between a 4 and a 4.9. I met with a urologist. It was funny. He said, well, we'll do a biopsy, and if everything looks good, you can get back on your testosterone. So he did an MRI first, and then he did a biopsy, and I've got a Gleason score of 3+4.
Okay, let's take a step back just to the MRI for a second. What was the takeaway from the MRI? Did it have PIRADS score as to
Yes,
what
it
they
did. It had a
saw?
score of 4.
Okay, and then
It worked.
when you got to the biopsy, uh, was that tra transrectal or transperineal? Do you know?
I don't know.
Uh,
They took 12 cores. Does that tell you?
okay. Did it come in, did they go in through your rear or
Yes, they did.
okay. Do
Sorry,
you know
grabbing my notes here.
I
does
thought you were going to
the
get up and show us something.
uh when they did the biopsy, were they using the MRI to guide where they were going?
Supposedly.
Okay. And this was done with your local urologist?
Correct. Yes, sir. Mm-hmm.
Okay. Okay. And you said they took 12 cores?
12 cores.
Okay. And you've got a 3+4. Can you tell us how many of the cores were positive?
4.
Okay. Of the 4, were they all 3+4?
That's correct. Yes, sir.
All 4. Okay, so you've got 4
Yep.
3+4s. Okay. Uh, if does your report tell you how much 4 was present? There are usually two numbers on the report, one that says how much of the core was cancer, and then the second one that would tell you what percent of the cancer was 4.
One core was 10%. Is that what you're looking for?
Yes. Well, I
Okay.
just want to check 10% 4 as opposed to 10% total cancer.
Well, it says RLM malignant 3+4 = 7. 10%.
Okay, that's a little vague. What do the other ones say?
One is 30%, and the two others are 50%.
Okay.
I mean, I can put the report on the screen.
Uh,
At least I could hold it up to the camera.
No, we probably wouldn't
Yeah.
be able to read it anyway.
Now
Okay.
that's we may want to take a look at that report afterwards, if you'll share with us, just to make sure that we're reading it correctly. Because I have a feeling the 50% means the amount of cancer in the sample and not the 4, but we need to figure that out because that could make a difference for you. On that report, are there any other notations besides identifying the 3+4? Are you seeing words like cribiform, PNI, interductal? Are there any mentions of any of those items?
No, there's a Parton table that I really haven't looked at before.
That's really just addressing what the 3+4 is.
Okay. There's a ICD-10, an R97.2, and a C61.
Not sure what any of those.
ICD codes are those are for the doctors. They're basically
Gotcha.
telling you
Okay.
what codes they use for your doctor and your insurance company.
Okay. So does that bring us up to date as to where you are, or is there any additional?
Well, I went to see a local oncologist, and he wanted to do, let me see, there's 2 different types of radiation. You'd have to tell me. I know one is proton, and then there's another one. He wanted to do, go ahead.
Go ahead. I was just going to say proton and photon. Is that what he was talking to you about? Okay.
I forget which one he suggested, but he wanted to do, he pulled out his, is it the NCCN document?
Mm-hmm.
And he said the protocol called for 28 days of radiation. And
Not really.
what's that?
But not really. He could do it in 4 or 5 days, but he doesn't have that equipment, so he doesn't tell you about that.
Yeah, okay. I have read about that you could do it in 4 or 5 days. Anyway, I'm going to the Mayo Clinic in Jacksonville next week. I'm going to see a Dr. Atia and have him review everything.
Okay. Do you know is that doctor a urological oncologist or a radiation oncologist?
Yeah, I had him pulled up. Let me see if I can.
Okay.
He's an oncologist.
What type of oncologist? Urological or radiation? Very important.
Very important. Okay. It's like when you're a hammer, everything looks like a nail. Is that right?
Yeah.
No,
It is
right.
first. There's 2 Dr. Atias at Mayo Clinic. One's named Stephen, one named Albert. So.
Oh yeah. This is not Stephen. It is Albert.
Okay.
Radiation oncologist.
Yeah.
Okay.
Yeah, I think, and Stuart will we'll finish up, but from our standpoint, you're getting ahead of yourself. And
Okay.
we'd like to suggest some steps before you do all of this, because you'll put you in a much better position when you do talk to your next doctor. And so Stuart, I'll hand it back to you.
Great.
Okay, so the first thing that we would recommend for you at the stage that you are is you need a second opinion on your biopsy. We can look further at your report, but one of the things that always comes up is when you have a local doctor or group performing the biopsy, the guy who reads the slides and tells you what you've got is not necessarily the most experienced at reading those slides. And this is the most important thing for you at this moment, is to get the best possible diagnosis as to what you're dealing with.
Okay.
And in the chat box over there, we have the name of two doctors, Dr. Jonathan Epstein and Dr. Ming Xiao, who are two of the best, most recognized experts at reading prostate cancer biopsy slides and giving you the best read on your situation. And it's a fairly simple process. With either one of them, you can direct, or the doctor can request that they send them the slides, and then after take them a week or two, they'll look at them, and they will give you a separate report back. And beyond the report, one of the great things about both these doctors is they will, after they've read the slides, will be happy to get on the phone and tell you what they see. And this is going to be fairly important for you, because your report right now says you've got 4 cores, which means you're most likely going to need treatment. But one of the things that concerns me is if those 50% are saying how much 4 is there, you're borderline. If those are right, you would be borderline 4 plus 3, which would change the treatment recommendation.
Gotcha.
So the very first thing, and it doesn't take a lot of effort, and you're on Medicare.
I am.
If you're dependent, I'm assuming you're on regular Medicare and not Advantage, in which case I can't speak to it. Medicare is going to pay for the second opinion on the slides. Otherwise, it's a few $100s. But it's the very best investment of your time and to getting the information you need, because if in fact there's any of these other factors, cribriform, PNI, intraductal, these guys will see it, and that too could make an impact on what the best treatment process is. Now, the other thing which you have done, it may be too soon, but the idea of going to Mayo as opposed to dealing with your local doctors is the right thing for you to be looking at. We encourage everybody, whenever possible, to get to a center of excellence, because the doctors there, are truly doing what is best, not what is the most economically advantageous for them. And they will also probably have the access to the broadest choice of treatments, so that they will, based on your case, they can explain to you the different options that are there and why they think one is better than the other, as opposed to, well, we've got this machine in the back room and that's the one you should have. So, but really the most important thing that you want to know right now is the best information about what exactly you're dealing with.
Got it.
The other question is, do you know from your from the biopsy that they did they run any genetic test, or
I don't think so.
which would be called a decipher or a Polaris? One of those tests, what that test does is it takes a sample from the cancer that they took out of you in the biopsy, and it looks at the DNA of that cancer and scores it in terms of potential risk of aggressiveness. And that, based on where you're probably sitting, is also something that would be important for you, because you're on the cusp between possible treatment options, and this score can help guide the doctors in the correct direction.
So I should have that done also?
I would definitely request your doctor to initiate getting that test done.
Does that entail another biopsy, or can
No, they take
Yeah.
the folks.
You'll use the biopsy material that they have already. So.
Okay.
So they just pack that off and send it to the lab, and the lab does their analysis and then sends the report back.
And the same with the second opinion. They'll send the slides to the actual Dr. Epstein or Dr. Zhao if you ask for one of them to get to your second opinion. So you won't have to get another biopsy. Nope, nobody would ever get a second opinion if it entailed another biopsy. I'm good with the first one. I'm okay with that one.
Yeah.
So, Bob, that's our primary recommendation, is going to be investigating those things before you get ahead of yourself in terms of what type of radiation or what the other types of treatment options are. That's all that can come down the road. And one of the things to just check is make sure that your doctor has explained to you that there's no urgency in terms of making a decision.
Yeah, they have said that.
Okay, that's good.
Yeah,
because
based on what you've told us, we would think from our experience and from the people, listening to your peers in this room, that you don't have to rush into anything with the diagnosis that you've got right now. So information gathering is better for you than to rush into any kind of treatment. And as you experienced, you go see a radiation doctor, and he says, "Oh, let's give you radiation for this because you've got a 3+4 and you had 4 positive cores." But gather more information first, and like Stuart said, get that second opinion. I did have one question about the PSA. You said you didn't get it for like 3 years, and when you did,
Correct.
it was a 5.4, or did I hear that wrong?
It was a 5.4. Yes.
5.4, and then you said, but it's hovering around 4.9. So how recently after the first 5.4 did you get another PSA if you had a biopsy in December?
Well, the original 5.4 PSA was in February.
Oh, okay. I thought you said September. Okay.
No. And then I had a PSA every 90 days in 2025. And it started coming down. But I noticed on the biopsy report, it has a PSA of 4.9, but I also had a local lab do it. And I got a score of a 4.0.
now different labs
Yeah, if you did this I'm sorry, Stuart, if you did get at the same lab and they did two different assay styles, or there's different ways to measure it, right? Different tests that
see.
they do. What's the right word I'm looking for, Rick? Methodology, or different
Protocols.
protocols. Yeah, that was the word I was looking for. Definitely. There's two. There's more than one, but I know of two protocols for PSA testing, and then there's the ultra sensitive, which I personally don't really care for, because I don't care what my PSA is doing in the third digit after the dot, right? I care. But there's a lot of guys that get the ultra sensitive and they want to know, right? But I want to know what it's like when it gets above .0 something. Then I want to. Then I'm going to start worrying about it. If it's .001, I don't care if it goes to .003. So,
Just
but
as,
If I go to Mayo, what type of doctor should I be seeing? Should I be seeing a radiation oncologist, or should I be seeing some other type of doctor?
So
So you did-
let me take
Go
a
ahead, Rick.
shot at that one. At this point, your entry point, in my view, if it were me, would be a urologic oncologist, a urologist. Not necessarily because you want surgery, but because they are, in our view, the best person to review your information and guide you what your next step is. And if they think that radiation is a good option for you, then they're going to refer you to the radiation oncologist. Now, it sounds like, and I missed some of your history, but it sounds like you're not a candidate for active surveillance. But if for any reason it came back, it turned out you only had you were all 3+3s and you only had a tiny little bit of 3+4, you could be a candidate for active surveillance.
I see.
There's a doctor, I think it's Gundian, Gundian, Dr. Gundian. We can check, but we've sent a couple of people to him. One of our moderators has been with him for a long time, and he favors active surveillance. So he's not going to recommend interventional treatment, either surgery or radiation, unless he thinks you really need it. Whereas where you are right now, they're already moving you straight into, let's pull out the radiation machine. And they're saying to you, well, look, NCCN says you need radiation, and that's 28 treatments of IMRT. And they're not even telling you that you could do this in 4 treatments or 5 treatments. The protocol's 5, but some doctors will do it in 4. But 4 or 5 treatments, which is a lot easier on the patient. But they don't tell you this because they don't have the equipment. Whereas at Jacksonville, they're going to go through all the different types of treatment. We're going to go through all the different types of treatment. We'll talk to you about the different types of radiation, if in fact you need radiation. We'll talk to you about brachytherapy. We've got one guy on here who just completed brachytherapy. We've got another guy on here who's done what's called MR LINAC. These are the cutting edge treatments that you can do in fewer sessions. That you're not going to hear about if your private practice community radiation oncologist or oncologist doesn't do them himself. And that's why we want you to keep coming back, and that's why we want to get you to the best possible treatment choice.
And so tell me the type of doctor I should see again, a urological oncologist?
Yes, a urologic oncologist. And I think the guy is Gundian, but again, let's wait until let's first of all, let's get the slides out. And then in 2 weeks, you'll come back and we can verify. Bill, I think, do you remember the name of the doc that Dan Gifford went to see? I think it was Gundian. It's the same guy that Gary Tosca sees.
I think it is, but I could ask Dan.
Okay, if you can just check with Dan. But we'll get you to the right doc at Jacksonville. And just like everybody said, fortunately, you're in a place where you have time. And even if your head's making you a little crazy and dealing with this, which is perfectly normal, you know, you can come to our Men Speaking Freely group, and we'll make you laugh and drive you nuts a little bit and get our arms around this anxiety, because that's what we do in that group. But you've got a lot of time, and we'll go on to listen to some of these other guys, and they're a little further down the path from you, and some of them, at least one, spent a lot of time on active surveillance before he decided to go to treatment. Does anybody else in the group have anything because I know we got a lot of people that want time. Anybody else in the group have anything they'd like to say to Bob from their own experience? Ooh, quiet lot tonight.
Yeah, Bob, you're getting good advice. That's what I'd like to say.
Thanks, Tim. Well, no, I'd like to say that I really appreciate the advice, and I didn't really know what to expect when I came to the group, but this is really good because that's what I guess that's what we all need is good information.
Well, I'm
Yeah, the
glad
more
that's
information you
helped.
can get, the better.
Are there any questions that you brought that you wanted to address before we move on? And David, then I'll come to you.
For me?
Yeah, well, dear Bob, were there any questions that you were hoping to hear an answer to that we haven't talked about?
Well, I'm familiar with the brachytherapy. I'm somewhat familiar with the radiation therapy. I'm familiar with, of course, I really don't want to have my prostate removed. Although they like to throw that out as the first option for some reason. And but I understand that there's a cryotherapy, and then there's someone that used to be in this group told me about an electrification therapy where I guess they heat the area, superheat the area.
My suggestion to you is
Sorry.
put all that on the back burner for the moment, because
Okay.
you can drive yourself crazy with the 73 different options for
Okay.
treatment. And
Makes sense.
once we know more about what you're looking at and you hear what the doctors say, we can sort of focus in on that. So you can just overwhelm yourself with too much information too fast. So I would stay away from that. David, you had something you wanted to say to Bob?
So far, people have been talking about the importance of getting information, and they talked about it in terms of getting information about yourself and the aggressiveness of the tumor. But one other great thing to do at this stage is just essentially become something of a student of prostate cancer treatments. And a couple of really easy ways to do that. One, keep coming to this group. Secondly, you can go on YouTube and watch past episodes of this group and use other guys' stories as case studies that you can learn from and see what they did and what worked best for you. And then if you have specific questions about a particular treatment or about 3+4 versus 4+3, one quick way to get some pretty solid information about those specific topics is, again, go on YouTube and watch videos by Mark Scholes. He's got this enormous library of hundreds of videos where he spends about 10 minutes on each of these discrete topics. And I would say most of the time, I think he's very solid on his answers. So those are three places you can go just to kind of get a better grounding in the topic in general.
Great. Well, I appreciate it so much. Thank you very
Okay,
much.
Bob, make sure you grab the information about the doctors from the chat.
I did.
And Our next meeting is in 2 weeks, and we'll make sure you get, if you give us the email, we'll make sure you get a reminder, and we'd love to see what when you come back and hear about what progress you've made.
Great. Will do.
Okay.
Thank you.
Okay, super. Amir and Sandra, what's the update? Where you're at?
Update is we had a great conversation with Dr. Rossi, and we have been in communication with David as well, which has been very helpful. And I'll let Sandra ask the questions. There are several questions that came up, and we have written them down. And she's go ahead.
Well, the first thing was, you remember we talked about the potential clinical trial, the heat wave trial that Dr. Kishan at UCLA had invited Amir to potentially participate in. Well, they ran the PROSTOX test, the cheek swab genetic DNA, and he scored in the high risk for grade 2 and higher urinary toxicities. So that immediately the PA, messaged in my chart and said, that kicks you out of the potential of participating in that trial for the apalutamide. So we're still wondering, this is a question in our minds, is it worth still asking Dr. Kishan if he would still do the MR-Linac? That's why we wanted to consult with him in the first place. And then he brought up this trial and all of that using the CT-based SBRT. But if he's out of the trial, then why couldn't he still do the MR-Linac? We understand there's some risk with that, but all the other people we've talked to at their doctors, they don't give the PROSTOX very much weight. They don't even order them themselves because they don't consider that test fully validated yet. So that's one question that's still floating around, I think, in our mind. Yeah, and or just go to OHSU and get IRMRT or possibly SBRT from them. We had the appointment with OHSU in early January, which Amir was only a couple of weeks out from his heart bypass surgery. And I re-listened to the appointments today. I recorded them, and I think we both still have this hesitation about OHSU and being treated there. It's just some of the answers we got don't align with like what we understand from AnCan and other recent, PCRI webinars and conferences and things. Just don't seem quite align with current information. It just seems a little odd. So that's, I think, just the concern we have about doing that. But the advantages that Dr. Rossi pointed out when he was looking at Amir's overall, his overall health situation and the heart surgery and all that was, how much value do you place on being treated locally, being able to sleep in your own bed, keep going to his cardiac rehab, on schedule and all that versus traveling somewhere else. So that's kind of what we've been discussing, but I don't know, the MR-Linac sounds promising in its, more higher accuracy and getting it over with in just 5 treatments and being done with that.
Well, I would reach out to Dr. Kishan and see what he says about just straight MR-Linac. Since UCLA is the place where PROSTOX was developed,
Yeah,
he will probably take it more seriously than some others. So, yeah, if you ask him, is this an option? Will you do it? He'll probably give you a strong answer, yes or no, because they believe in the test, and either he thinks it's okay or he thinks it's a risk, and that's something you really want to obviously sort out.
yeah. The funny thing was on the last PCRI conference they had, I think it was November, he did a presentation and the moderator, Mark Moyet, at the end asked him this exact question. If I were to get a PROSTOX test and I tested high risk, but I still wanted to get SBRT from you, would you do it? And Keishan's answer was, well, I would consult the patient and, warn him that there was higher risk because of our test, but yes, I would still do it.
Okay.
Sort of this is for a hypothetical, question on a webinar.
Well, I
Yeah.
would definitely, ask him about that question.
Okay.
Just remind me, because I apologize. Dr. Rossi is which type of doctor?
Peter Rossi's who treated David.
Okay, so
yeah,
urological oncologist or radiation, David?
oncologist. Yeah, he
Okay.
does brachytherapy as well as other forms in the kind
Okay.
of small town near Aspen in Colorado that we've consulted with twice. He really, rather than sort of putting people in a bucket, he really seems to just really consider his patients, like all aspects of their lives, rather than, every place else we've been, it's like, oh, you're a 4+3, you're this, you're that puts you in this bucket. Here's what we do. So it was really, really helpful. Good, like Amir said, it was a really great conversation.
Rick, you have your hand up? You're on mute.
Yeah, there's a new chief at of the radiation group at OHSU.
Yeah,
who's
Yes.
really good. His name is, sorry,
yeah, Howard Sandler, yeah.
Howard Sandler.
I don't know that there's any way to be able to actually get an appointment with him. I don't know.
Well, I can probably do that for you if he's seeing patients yet.
Yeah,
because the problem is these guys who are coming in, they have to get licensed in Oregon. The Oregon process is slow and it's frustrating. And if he's seeing patients, and I can find out, I think we could. I think we could get. I can get. I don't know for sure. Can't say yes, but I think I may be able to get you an appointment with Dr. Sandler. I'm trying to. Where did he come from? Was it Washington? Washington University. I'm just looking it up. Where
Cedar Sinai, I believe. Was it Cedar Sinai?
Oh, Cedar. No, I don't think. No. You might be right. I can't. I honestly can't remember. I have to look it up. He came from a. I do know he came from a pretty well-established institution, and he comes with a really good reputation. Yeah, Cedar Sinai. You're absolutely right.
The other thing that they ran into was that Rossi turned them down for brachy for fear of complications involving Amir with the anesthesia. And I can't remember, but it might have also been an issue with his existing urinary situation. Is that correct?
No, mostly it was the anesthesia he was concerned about too soon after that open heart surgery. That was his main thing. And, he suggested OHSU would be sort of fine as long as they're doing the most advanced modern versions of IMRT or SBRT, which he said should be MRI based for the planning. And I looked at the radiation oncologist, the interim head, it's Dr. Arthur Hung, my notes and listened to the recording again, and it's CT based, their planning. It's not MRI based for even just IMRT or SBRT there. So does that mean it's not sort of as good as we could get? I don't know.
MRI is better than CT in terms of specificity of imaging for
Yeah,
what you're talking about,
yeah,
both for planning and also for actual treatment.
yeah,
Yeah, I get the idea of being close to home, the benefits, as opposed to traveling. But the other thing, which is really important, is you've got to have 100% confidence in the team that you're working with.
yeah,
And if you have misgivings now, you run the risk of regret later. And that's really one of the things that you don't want to be setting yourself up for. The goal is to find the doctor that you feel comfortable with, that you feel is totally gets your situation and is a good doctor, so that you can place your trust in them and stop worrying. And if there's anything lingering in the back about, well, I'm not sure about this, and if it went wrong, I'm going to be sorry. Yeah, I've been there. That was the first doctor I talked to. I basically reached that, and I think he's a really good guy and a really good doctor. But I knew that there was always going to be that question, and instead, I went and found somebody that it may not go right. I may still have, I may still, down the road have issues and recurrence or whatever, but I am 100% comfortable with, I made the decision that I was most comfortable with and that I could live with. And that's really where you got to get to before you sign on the line to basically proceed.
That's a
And
really
anybody,
That's a really good point. The issue they're running into is it probably wouldn't be Kishan doing the IMRT. It'd be an underling, maybe even at a different location. I'm not sure, but that was sort of the impression I got. So once you get down that far, and with IMRT, is it likely to be better than IMRT somewhere else?
well, this is where you come down to the doctor and your trust in the organization.
yeah.
In most cases, it probably may not make a difference, but it's really what makes you feel comfortable that you can put your head on the pillow at night and not worry.
Yeah. And I think we are interested in at least asking about the MR LINAC, the SBRT instead of just IMRT. So that would give me, I don't know, more confidence
More confidence.
if you're going with that.
Yeah, one thing that, as Sandra said, we noticed with Dr. Hong at OHSU was he seems to be behind the study. Based on all the conversations we had with MD Anderson, Dr. Kishan, Dr. Rossi, David, and all the research, and you guys, he seems to be not up to date, and that kind of concerned us, and that's why we hesitating going the OHSU direction.
We are a pro OHSU family. His son was born with a really super rare anemia disease. He ended up having a bone marrow transplant there, doctored there his whole life. I donated a kidney to that said same son, at OHSU. So we're not anti-OHSU. It's just there's something about this, and I don't know what it is. Just, yeah, it feels like they're not up to date. They're not the most progressive, at least yet. I know that it's going to change, but how it stands right now, it just hasn't been.
Yeah, then there's definitely something to be said for Stuart's comments about being comfortable with the doctor. if you're having these kind of feelings about that facility and the doctor that might treat you, then it might not be where you want to go, because you don't need that added stressor in the middle of Amir's treatment.
Yeah.
Yeah.
The one other little quick update, and we got to let everyone else go, is we trying to chase down a cardio oncologist. We did meet with Dr. John. He recommended Dr. Mosley at UCSF. We asked his normal cardiologist, not the surgeon, but the regular one, for a referral, and also to the one at Fred Hutch or in Seattle. And he happened to have been colleagues with Dr. Mosley at Johns Hopkins. He said he knows him very well, so he put in a phone call. So far we have a April 15th appointment, which is pretty far off, but they put in a word to try to get it sooner if it's possible. They have a triage kind of a deal with so many referrals coming in apparently, so we're waiting to see if we can get that sped up. It's a big debate about ADT, and his cardiac situation just continues to be blurry. So we're on
Okay,
it. Yeah.
good luck. Keep at it. We're here well, obviously we're here for you. Come back in 2 weeks and give us an update.
Okay. Thank you.
Thank you.
Thanks. Brian,
So I want to tell you that the hot word is that Dr. Sandler isn't going to see that many patients. I think he's probably got his hands full trying to get the part, get it. And I'm trying to read this other message. I think there's, yes, I see what it says. There's some sympathy about Hung. The person who's sending me the message is empathetic to your position about Dr. Hung. If we pushed, we could probably get Dr. Sandler for you. I will, so keep that in the back. But I mean, I kind of agree. If you can get to Kishan and you can see Kishan, it's not too many days away from home. If you'll do it with SBRT, I'd go for it. The other option, which oh wait, no, it's going to require an anesthetic. I was thinking HDR, but it's going to require an anesthetic if you HDR.
That's why Dr. Rossi just didn't think it was. He said keep it in a hip pocket for some time later if he had.
But I think there's a good chance we could do it. But I don't want to say I promise you. And it would take, rather than a text, it would take a conversation, and I don't want to do that right now. But just so don't rely on it, but it's possible we could get you.
Okay.
But I didn't get my question answered as to whether he's seeing patients right now, just that he's not going to be seeing a lot of patients.
Yeah. But even if he did, would he actually perform radiation therapy on Amir? So we.
Well, if you had the consult with him, he's going to be involved in the planning. It doesn't really matter who's performing. It's the radons don't actually operate the machines.
Yeah. They
just draw up the plans and they do it. Now, sometimes they're actively involved. So, for example, if with brachytherapy, the radiation oncologist can be actually involved in the placing of the seeds or with the rods or what have you. But most of the time, if it's SBRT or IMRT, they're working with the physicists and designing the therapy and watching it. It's sort of a hands clean.
Yeah. Thank you so much.
okay, great. Brian, you're up.
Okay.
Thank you. I'll just make it quick because I talk too much. And I'm going to go to the active surveillance group. Hopefully that's a better group I really like this group though. So I went to a urologist on Friday, the one that did my procedure a while back. I went to the VA a couple weeks ago. I kind of didn't get any information from them. Like I was telling you guys, no, I couldn't even have a conversation with them. No MRI before the next biopsy. But I went to my community care guy that did the aquablation 4 months ago. Had a great conversation with him. I got notes here. Had a great conversation with him. He says, "Yeah, we can do it. We can do it. We'll do a biopsy. It'll be in 6 months from now. We'll do the MRI guided biopsy, fusion guided, which I learned from you guys." I had a great conversation with him. He even said, "I said, have you heard of Epstein?" He goes, I have heard of him." So he's going to send the slides to Epstein that were that they took out of the aquablation. I know they might be messed up, but he said he would do it anyways to see if I could get a different reading. And he also said, I said, "What about biomarkers? Do you do any biomarkers?" I learned all this stuff for you guys. He goes, "Oh, we can do biomarkers. We can do a Decipher score." I said, "Perfect. That's what I want to do." So it was great. The only thing is they do transrectal biopsies, just like the VA. And this is community care in Seattle. So that's the only thing. So I did call Medicare today, and I know David, you tell me about this. So I did call Medicare today, and I'm working on that to see if I should go there to do like the UW or the I'm kind of scattered here. Or Fred Hutch. I don't know if Fred Hutch is in the Medicare network. So I just wanted to give you guys an update. And then also, Bill, Rick was asking you if you knew somebody at the VA. I think last time we talked, Bill Franklin, Seattle VA doctor or something. I don't know if you remember or not. That does perennial biopsy.
Transperineal, yeah.
Yeah, that one. Because they told me they don't do it. The VA doesn't do it.
I'm looking at my notes.
If not, they told me they didn't do them. And then the community care, they don't do them either. They said they just don't do them.
So there's nobody in Seattle that does
Well, no, there's
They
people.
do them. They can send you out to somebody. That's the whole point of community care. They'll send you out to somebody at Hutch who does it.
Okay, I have an appointment this Friday with my regular doctor at the VA, so I'm going to work. That's my next step now, is to talk to him. And
David, you got your hand up.
Go ahead, David.
Yeah, last time when we spoke about Medicare, what I should have done was ask you exactly what do you mean by Medicare? Because when people use that term, they can mean Medicare without a supplement, Medicare with a supplement, or sometimes they mean Medicare Advantage. Which one do you have, Brian?
Medicare without a supplement, because I get all my care through the VA.
Okay. If you ever need to go somewhere and use your Medicare without a supplement, since we last talked, I did my taxes. And one of the things I did, just more out of curiosity than anything, was went through all my medical expenses last year to see what things cost. And I happen to be on original Medicare with a supplement, but the supplement I have is the high deductible G plan. It's just like the G plan in terms of coverage, but I have to pay a deductible until it is $29.50. So that means until I hit $29.50, I'm kind of in the same boat as you, which means I have to pay out of pocket when I see a doctor or get a procedure. And the thing is, when you are on original Medicare without a supplement, Medicare pays 80% of it, but that's a discounted price, and you pay the other 20%, but that's also a discounted price. And let me give you a couple of examples from my own year last year, and I saw like tons of doctors, tons of specialists. And I'll just give you one as an example. And this is just like if you wanted to have a consultation with somebody at Fred Hutch, and I'd be shocked if Fred Hutch didn't take original Medicare. But like last year, I saw Albert Chang, okay, major specialist. His original charge, and this is kind of a fictional charge that everybody, pumps up, was $1,360 to have a consultation with him. Medicare approved $186. The amount Medicare paid was $146. And I was left with a bill of $38. $38 down from $1,300. Now, if I had had Plan N, which is a really good plan supplement, I still would have had to pay 20. So I'm just saying, when you, even without a supplement, though all those the discount plus the 20%, it really melts down to a usually a pretty small amount if it's a consultation. Where it gets more expensive is if it's a procedure.
Okay. Yeah, I called and talked to him today. The lady walked me through it, and it was like, the perennial biopsy. I used all the right terms. So I'm just kind of getting started with all that. Just kind of because I got the VA, I got community care, but none of them seem to do it. So I do got the Decipher score. I got the slides being sent to Epstein. So I think that's a good positive. Even though they might not be the best slides, I can always send my new ones. So I think I'm, oh yeah, and you guys mentioned some doctors. Dr. Montgomery, Robert Montgomery, Larry in Alaska, and then Dr. Lind at the Fred Hutch, Dr. Daniel Lind. So I got all these names. So I'm going to talk to my doctor Friday, my regular doctor, and we'll just see what he says. If I can get referred to through community care.
So the one thing I want to tell you is, don't be put off if they say, no, we don't do it. They do it at community care. The whole point about community care is that you can go outside of the VA to get the treatment that you need if the VA doesn't do it. So if VA doesn't do perennial, then perineal, then you can get it outside. That's what community care is there for. Correct? I'm right, aren't I, Bill? And so they will send you to Hutch, where they do perineal, and that's how it gets done. They just have to give you a referral to Hutch, and we can talk to you about docs at Hutch, urologists at Hutch. But don't be putting it in your head that you can't get a perineal biopsy because you're at the VA.
Okay, I just remember my regular doctor there once upon a time said, yeah, we just do a 12-core transrectal, no big deal. And when I see him Friday, I just have a feeling it's going to say the same thing. And when I ask for a referral, that'll be the test, I guess. I mean, they did refer me to.
That's for the referrals. I would prefer transperineal. And if you guys don't do it in the VA, then I want to go out on community care.
Okay, I'm going to do it.
It can't hurt. I mean, and yeah, that's work. Like Rick said, that should be a way it works. If you're insistent upon the transperineal, they should give it to you at community care. And somebody in Seattle does transperineal, I'm sure.
I'm gonna. This is Henry. This is Henry. I'm gonna chime in a minute. Because I use community care, and I always have used community care. You're gonna have to do a little bit of your own research. Find someone outside who does transperineal, and once you find that location, you can submit that information when you make contact with community care. If they're within the network, within your location, you can tell them, this is the location I'd like to go to. This is what I want to have done. It's really not that complicated, and you maybe you have to do a little personal phone calling to find locations that gonna do the procedure that you want. That's about the hardest part of it right there.
Okay, thanks, Andrew. I remember you told me last time you talked about the Fred Hutch, I think.
And you know, go to Brian, go to the vets group tomorrow night.
Man, I can't go for about another 6 weeks. Tuesday night, I can't be there. I'm sorry, I can't. I go Wednesday, Monday. I got to be somewhere else.
Okay, you know, it's fine, but that's where you'll get the answers to some of these things. You'll get the Henrys who have done it before, and they'll tell you how to do it.
You know, maybe I'll cancel my prior engagement. It's for about another 6 weeks, and I'll be there. Okay, that's all I have. I just want to give an update, and I appreciate everybody here. Thank you so much. Appreciate
Great. Mark, you're next.
Hello.
Hi. What's up? What we can do for you?
Just wanted to check in and let Rick and the group know that I underwent the HDR brachytherapy procedure on last Monday with Dr. Chang at UCLA. It went really easy and smooth. The people there were incredibly attentive and professional. The good news was that he came in to see me afterwards and told me that I only needed one dose and one treatment. And so I didn't have to go back for the follow-up today. Side effects have been minimal so far. Strangely, the biggest problem I've been dealing with is they kind of tweaked my lower back. I think when they moved me around in the operating room, you know, for the pre-procedure type of tests and insertion of the rods and so forth. So I've been dealing with that for a week. It's been kind of unnerving because it's been painful and limiting in terms of physical abilities to do stuff that I normally do, even just walking. But other than that, so far so good. Very appreciative of the efforts there. And I'll have a follow-up with his PA on Thursday morning, and then I'll have a follow-up later on Thursday with Dr. Scholes over at Prostate Oncology Specialists to update him, and I can report back after that.
Great. That's good news. Can I ask one question?
Sure.
Did you have a catheter coming?
Yes. Yes.
How long?
They had no, not post, only during the procedure.
Oh, okay. I was just curious because we had somebody else we're talking to who's considering it, and that was one of the questions that we were trying to get a fix on. So
was it something they were concerned about or just curious?
I guess concerned about just trying to understand the post period as to whether, because there's just different stuff we were reading. Some said yes, some said no.
I did have a catheter for 24 hours.
Yeah, in my case, only during the procedure. They told me that they were going to use it in part to inject, I think it was a saline solution or something, so they would get clearer imagery on CT. And then they drained it afterwards. And I guess it was voided completely by the time they discharged me. When I came home Monday evening, the first time I urinated, it was quite painful in the burning sensation, to the point where I was like, geez, I'm not looking forward to having to pee again for, you know, the next week. And then the second time on Monday night, it was very similar. By Tuesday, it had diminished significantly. I'm not sure if that was just the normal course of recovery or if that was aided by the Flomax that they asked me to take at night. And by Tuesday evening, I literally didn't feel a thing, and haven't since then in terms of urination. So, you know, what they cautioned me about as far as, you know, possibly experiencing the burning and giving me a special drug that they told me would turn the urine orange if I had that. I didn't even need to take it. I didn't need to take the narcotic for any pain. And I literally have had no swelling or pain anywhere else, you know, from the procedure. So far, I've got my fingers crossed that everything went well.
That's great news. We're happy to hear it. Okay.
And Rick, just so that you know, I had a very nice long conversation with our friend Steve over in Malaysia on Saturday. And he seems quite on top of things. He's quite aware of his situation and all the options that he has. Clearly, he's at a disadvantage being in Malaysia, trying to coordinate these things and possibly having to pay out of pocket for things. What I did was I forwarded him the clinical notes from my procedure so that he could see all the things that were done, because some of those are things that I'm not even aware of. You know, I was under sedation or anesthesia when they did a lot of these different things. But I told him I would also get him a copy of the EOB once I receive it from Blue Shield, so that he could see what the breakdown was, because he was checking on the cash price versus the insurance and the Medicare. So he was very appreciative, and we had a very, very nice conversation and stayed in touch by email afterwards. So more than happy to help if anybody else wants whatever information I may possess.
So Stuart is also working very closely with Steve, closer than I am, to be honest. And we're really glad you got to speak to him. He was concerned about the catheter, but I was fairly sure you didn't go home. And I think David may be the first person I've ever come across who did go home with a catheter. I've not known too many. And not with, I had seeds back in the day, and there was no catheter. They just made me, they usually just make you stay there until you can pee, and then once you pee, they let you go with either HDR or LDR, depends. So really pleased, and keeping our fingers crossed for you so that this is the end of it. And anybody else have any questions in the group about Mark's procedure?
Well, I'll just say that by avoiding the catheter, you avoided the single worst part of the whole procedure for me.
Oh boy.
Yeah,
that sort of reminds me of when my urologist, after all of my treatment a couple of years later, and I had a touch of radiation cystitis, kept telling me I'd have to have a cystoscopy, and I kept, oh, do I really have to? I really have to, because I really didn't want to do it. And then he said, well, if it bleeds one more time, you've got to have a cystoscopy. So I said, okay, Joe. So it did, and I went in, and the whole cystoscopy was a nothing. So, there was no reason to even be worried about it. So there you go.
Well, you're a braver man than I. When I had a cystoscopy, I asked for nitric oxide, and
really?
yes, I did, and had to pay $100 out of pocket for it too. They put it on my put the mask on my face, and I'm breathing, and I'm trying to hyperventilate that stuff in to knock myself out, and I'm still wide awake, and I'm staring up at the ceiling, and the next thing I know, the doctor said, "Okay, we're done," and it was I must have passed out, and I didn't even realize it.
I didn't know that was an option, guys. I've had more than one. If I could get the gas, I'd ask for it next time.
Yeah. Let's keep going. We got a few more people. Tim, you want to give us an update?
Yeah, I'm an SBRT patient at Moffitt Cancer Center in Tampa, Florida. My treatment ended on October 30th, 2024. So I'm 15, almost 16 months post-treatment. And my PSA is rising. On July 30th, it was, oh, by the way, first of all, it was 6.6 before treatment. On July 30th, 2025, it was 2.3. On October 30th at Moffitt, it was 2.5. And in January 2026, January 20th, it was 2.99. I got that at a health fair. I also am part of a local prostate support group called SPI, Sarasota Prostate Initiative, and they have clinics and health fairs where I help other guys, and they have free PSAs every month. So I know that I've been warned that there could be a rise or a bump. So maybe that's what I'm experiencing so far.
How old are you, Tim?
I'm going to be 65 this week.
Okay. Didn't you tell us you were retired before? Which that has nothing to do with your age. I just thought I thought you told us you were retired, and I was thinking you were a little bit older. But I mean, 65 and 2.9 is not high. I mean,
Right, but the trend is creeping up. It's instead of down. So I did submit my data to Moffitt. They're aware of everything, and their response was, "We'll see you on April 30th on our next meeting, scheduled meeting." So
Was 2.3 your nadir?
to this point, yes.
Now, keep in mind, because you had that one of those tests that may have been run by a different lab, that there's some
All of
variance.
the tests were run by different labs.
Okay, now keep in mind that the amount of difference you're talking about could be attributed to the different labs.
It's not very large.
Were more than one of them done at the Sarasota Prostate Initiative? I know I get their emails.
Yeah.
So you go down there and get the blood.
I either participate in person or online. Yeah.
If 2.3 was your nadir, then this would not be a recurrence until it hits 4.3. And you're still I mean, it's going up. But when did you have your SBRT? What was the date of that?
It ended on October 30th, 2024.
Well, you're definitely below 4.3. So you haven't hit the definition of recurrence. And I do know that PSAs can do some funky things after radiation that are sometimes quite meaningless. So I wouldn't freak out.
I'm hoping it's the proverbial bump in the road.
Yeah. So Stuart's point about the labs, Tim, if your doctor uses a particular lab, or even if you just go to Quest, I mean, and again, these are not high numbers. It is, if you look at the numbers, it's a rising trend. You can say that based on these three numbers, but I would say go to the same lab every time. Like I go to Quest every time for my lab test, and I have the chart, for the last 10 years because I've always gone to the same place. So they do the same test every time, the same, what's that word again, Rick? Protocol. Yeah, they do the same protocol test every time. I swear my mind went blank right when I thought about it. I mean, I would do that this is 6 months of testing, right? From July to now. 0.6 rise is almost nothing. It is a rise. I mean, I go back to my earlier statement about the ultrasensitive PSA test. Yeah, it's above the 0.0, like I said, but definitely keep an eye on it. Of course, you have to because of the situation we're all in. But I would start looking at a trend where I go to this. I'm sure the same lab did it every single time. That would be my personal advice.
Were you on ADT, Tim?
No.
Okay. And what was your Gleason score before you were treated?
3 + 4 = 7 from Dr. Ming Zhao.
Okay.
I was the first AnCan to use him.
Rick, did you have something?
Yeah, so I'm not exactly comparable to you because I was on a lot of ADT. But when I came off that ADT, my PSA started to rise. And it would rise, and I was tested monthly at Kaiser. Although my main doc, radiation doc, was Mac Roach at UCSF. And each month it would come back up and it would go up a little bit. And I'd send a note to Mac, it's 0.1, 0.2, Mac, 0.3. And every time, don't worry, it's going to come down. Don't worry, it's going to come down. This went on for 11 months. Don't worry, it's going to come down. And he was right. He got all the way up to 0.9, 0.92 or 0.93. And then it came down. And thank God it's been less than 0.1 for many, many years now. I never understood why that happened. It has to do, this is not the reason for the bump, but the reason for my particular pattern had to do with the ADT. And one time I was at a conference sitting next to Stephen Frank from MD Anderson, and he drew me a little graph on the back of a napkin, which I still have, but I did redraw that graph onto something that I was able to scan into the computer. So I do have that graph now. And I actually talked about Elenia Stathiou about us writing a paper together because it would help a lot of guys and ease their anxiety when they come off. Now, your situation to me sounds like a classic bump. And, you know, that's also the reason why people get cystitis. Paul, who's on the call tonight, you know, has been concerned with his cystitis, and it's like that 18-month period, year to 18 months after you have it, you see a bump, or you see radiation cystitis, or you see radiation proctitis, because radiation's the gift that keeps on giving.
I can attest to that. I've had several bouts of radiation cystitis since my treatment. So
Hang in there, Tim. Don't jump to conclusions.
Yeah, some days are better than others, but I'm handling it pretty well.
You know,
yeah, and thank you to David for reminding me about the nadir. There's a name for that nadir too. The something they call that's the something protocol, or the something nadir. What's it called, David? I've forgotten now. That 2 plus 2 plus
2.2 points. Oh, it's called the Phoenix Protocol.
Phoenix Protocol. I should remember that now, shouldn't I? The Phoenix Protocol. That's what it's called.
Yeah, because it rises from the ashes.
It's considered a biochemical recurrence. And Tim, you're not close to that yet.
If you talk about the nadir being, 2.3, and you're worried about a 2.0 rise at your current rate, you've got another year and a half to worry about it before you've actually gone above your nadir, 2 points above your nadir. So yeah. You could look at it that way, if that alleviates your stress level.
Yeah, Tim, that could turn your hair white in 2 years.
Okay.
Or it could be worse. Your hair could fall out, guys.
Okay. Moving along. Albert, thank you for hanging in there. You wanted some time?
Yeah. I was actually able to get an appointment with Keyshawn and did a virtual visit with him. And spoke with him about doing the heat wave trial and doing the MR LINAC, and it sounds good to me. One thing that's been going through my mind is, do I need a urologic oncologist? Because I keep coming back to, well, I know last time we met that y'all pitched in and thought, don't do surgery, I don't even know if I brought up brachytherapy, but I'm really not exactly sure why I shouldn't do one of those. So that's one thing I wanted to address. But I'm going to do the PROSTOX test and see if I would be a candidate for the heat wave. And I like the heat wave because they do the adaptive radiation therapy, where they redial your treatment every day. And I think I'd be okay with doing the apalutamide if it doesn't go well, could switch to something else. But so those are my two big questions about, should I get a urologic oncologist to help me make my mind up about which treatment to do, meaning radiation or brachy or surgery. I know the group has steered me. I felt like people seem to think radiation would be best. I watched the Scholl's videos, and he said, he thinks surgery shouldn't be done that much. But do y'all have feedback on any of that?
Well, I think at our last meeting, didn't you say that a couple of meetings prior that your doctor had recommended the PSMA test? And
Oh,
you were going to get one. Did you ever get a PSMA test?
Yeah, it came back negative. There's no spread. There was a new lesion in the prostate. All my lesions, I had 3 on the left side, and now there's 1 on the right. I spoke to Keyshawn about it, and he thought that was inconsequential in terms of radiation because they'll just treat the whole prostate anyway. But like I say, I'm leaning towards doing the MR LINAC or doing the heat wave, but I just want to feel like I didn't disregard surgery or brachytherapy without more research about it. And that's why I wondered if I need a urologic oncologist to help me with my decision.
What's your Gleason and your age, Albert?
Well, I'm 70, almost 71 in March. And at Mayo, my Gleason was, I had 2 lesions that were 3+4 and 1 that was 4+3. And Epstein graded them all. Well, he had 3-4, 3-3, and 3-4. But his 3-4, I've spoken about this before, was the one that had the large cribiform morphology, and 50% of that lesion was pattern 4. So he was like, well, you could have 1 more percent and you would have been, actually, yeah, it was 50% Epstein. Mayo said 60% of that most worrisome lesion with the large cribiform was pattern 4.
Well, our opinion is that you go with Epstein, but the difference between 50 and 60, even though the grading changes, it's probably not that big a difference. If you're 70, while we said earlier that you wanted a urological oncologist to help talk about and evaluate, I think that's really just sort of gilding the lily at this point. You know, you're talking to Dr. Keyshawn, who's one of the best in the world. You know,
And if you really want to start, if you want to talk about breaking, do what Mark just did and what Steve Lewis is doing, and talk to Albert Chang. Now, who's going to compare the Breaky to the MR Linac? That's what Steve Lewis is wrestling with right now. And it's hard. I mean, I don't know that there's an expert that we can think of who could really help you make that decision. Should I do Breaky? Should I do that? You know, Steve Lewis is more concerned about recurrence with the Breaky than in the MR Linac. But frankly, the chances of recurrence are high-ish across the board. When the problem is when they give you the recurrence numbers, they don't give it to you by Gleason grade or by whether you have crib reform or not. They give you a number. This is what we experience. Well, you know, there's a lot of people who don't experience any recurrence, and they're the people who have 3+4 and nothing special. And there's a bunch of people who have recurrence, and they're the guys who are 4+3 or 4+4, and they got fancy things going on. So it's really, really hard to make that comparison. You know, David, our man David here, might be more informed than a lot of people, because I am certain that he compared MR Linac to HDR Breaky. Is that true, Mr. Sharp?
That is true. And I'm going to quote Kishan here, who was quoted in a Backtable urology podcast within the past year. Now, in my case, I got the Breaky plus they did the pelvic lymph nodes. According to Kishan, who's the SBRT guru, right? So he's very much all about SBRT. He said doing that combo approach has a better chance of reducing, does a better job of reducing the risk of a recurrence more than SBRT by itself. But if you're looking at just SBRT or just Breaky, I think it's pretty close either way. It's almost like, what would you rather do? Go in 5 times and lay on a table and, you know, just get up off the table a little while later and go about your day? Or do you want to go in the hospital for the better part of a day, a full day, and have needles stuck in your crotch? And then, you know, it's one or the other. So one of them you get done in one day, and the other one you get done in 4 to 5 days. The odds are, I'd say, about the same either way.
But better if you do the combo, which you did.
Well, it depends on your specifics. I mean, I was definitely a 4+3, a solidly a 4+3. You're kind of like borderline. So I would not I'm not going to make a recommendation, because I'm not capable of doing that. I would say that's something you would want to talk with somebody like a Kishan about. But if you're going to UCLA, I mean, just like Mark was saying, I mean, one of the best Breaky people in the country is Albert Chang. So you got the best beam guy and the best Breaky guy under the same roof. You can't go wrong either way, I don't think.
And what was the thing you supplemented Breaky with?
Just IMRT to the pelvic lymph nodes.
Yeah.
Now I did a different kind of Breaky. I did something called MRI guided Breaky. And when you add the MRI, it sort of plays the same role as MRI does with biopsies. It creates much better visualization. The doctor who is really the pioneer of that is the doctor that Rick mentioned earlier, Stephen Frank at MD Anderson. But I went to a different doctor who was also kind of a pioneer of that, who was in Colorado by Peter Rossi. Mm-hmm.
Yeah, yeah. Okay. Okay, well,
Chang is good. There's nothing wrong with Chang. Now, according to Amir and Sandra, who checked into it, though, Chang doesn't do the MRI guided brachy, but Chang has a stellar reputation.
and then why did you do the lymph nodes? Was there evidence of spread, or did you just want to do that as a precaution?
It was a gamble. In essence, I mean, when you do both, you're taking a risk because historically, going back to the Ascend trial and more recent trials, when you do both like that, you raise the risk of possible more severe urinary problems.
Oh, okay.
And so it's not just the same. I mean, the more aggressive the treatment, when you throw in the lymph nodes plus the brachy with
Yeah.
IMRT, you're gonna raise that risk. So I tried to offset that risk with the MRI guidance and by going with somebody who was super experienced. And that's the thing about brachy. You'd never want to get brachy from just like the local guy. With beam, you can go to a lot of people and get competent beam, but with brachy, you either want the yo-yo ma of brachy or nobody, right? So, but if you're at UCLA, you've got the yo-yo ma of beam.
Yeah. And then back to surgery. I don't hear many people talk about doing surgery.
We're not going to. We're not going to tell you not to, but you're 70, and
Right. Some doctors might preclude surgery for you because of your age.
Oh, I see. Okay.
Well,
You're 71 years
you know,
old.
we see more and more guys in their 70s getting surgery. It's not unusual. We've had a bunch recently in the high risk group. I don't think if it were me, I would not do it at the age of 70 because it's a very tough surgery where your feet are above your head for anywhere from 4 to 6 hours, depending on complications.
Wow.
There's a lot of anesthesia, and you know, at 70, it's not worth taking the risk. At 55, it's fine. When I was diagnosed, with age 56. I would have done surgery, except that the nomogram told me it was very, very likely I probably needed radiation and hormone therapy anyway. So I didn't do it. But at 70, I mean, there are doctors, a lot of the good doctors would do it now. I'm sure Frenda would do surgery on you in a heartbeat. But I personally don't think it's a very smart decision at the age of 71.
Albert, I was 51.
Wow.
I had more advanced cancer than you, but I was 51 and I was in good shape. And my recovery from prostatectomy was very rough.
Wow.
So take my experience into account, but I agree with Rick. I wouldn't even consider surgery if I was you. Your 5-year survival rates are the same with brachy or with the SBRT. So there's no sense in doing something as invasive as the prostate cancer surgery, a prostatectomy, when you can get the radiation treatment. Like David said, you can go in for 4 treatments or a 1-day treatment if you don't mind needles stuck in your groin. And you're, all of the survival rate information is pretty much the same. Now there will be side effects from your treatment. Every treatment has side effects, and you're searching for a treatment. You've been in here for a while and talking about treatment, and you're trying to decide what to do. I mean, we can't tell you what to do. It's going to be a personal choice, but we can tell you that every treatment is going to have side effects.
Albert, another thing to consider, and this is controversial, doctors fall on either side of this debate, is a rectal spacer. I got one, specifically the Barrigel one, which has the reputation for being better than Spacer. Other people don't get it, and other doctors, well-known, respected doctors, don't use it. So that's just something to factor in.
Yeah, Keyshawn recommended it. I don't know
Did he?
which one. Yeah.
Albert, you're at UCLA and you've got two of the best radiation doctors, as David said. You've got two of the best radiation doctors in the United
I
States.
feel very comfortable with him.
And you've already had an appointment with one of them. So
yeah,
I'd stop shopping around, man. You're at UCLA and you've got two of the best docs in the country.
Yeah.
If you're going to need treatment, don't get surgery. The side effects and the recovery are much worse than the radiation will be. I will tell you that from personal experience because I had both. I had surgery and radiation treatment. So.
Okay. Okay. Thank you.
Okay. Ali, thanks for hanging in there. What would you like to talk about this evening?
Well, I'm actually in the wrong group tonight. I saw the email and I didn't even read it. And I was wondering, oh man, it's Monday. I thought it was Wednesday. Let me go in. I didn't read the email. I just saw AnCan and today? Okay. But typically I'm in the AS group. And I've been on AS since 2020. It will be 6 years in this November. I was diagnosed November 2020. 3+3, less than 5% of one core. I think since 2020, I've had 3 biopsies and only that one has came back with less than 5%, 3+3. So my question was actually in regards to, because I thought I was in the right group, was in regards to, because I currently take finasteride for my BPH. I have quite a large prostate, and it was recommended 2 sessions ago that I should switch that because of the long-term side effect of finasteride. And I was trying to get some recommendations because I have an upcoming meeting with my urologist in March. So I wanted to have, research some of the other alternative to finasteride. That was my question. So maybe I'll just wait until Wednesday.
Unless any of the guys here have experience to share, as a general rule, those are questions that are better answered in the Wednesday group because they have more experience with that.
Yeah, but I stayed by because this was really interesting. And last meeting, someone was recommending that maybe some guests should come in occasionally from this group, or maybe the even advanced group to come in occasionally and talk in the AS group. And well, I don't know.
Well, I mean, some of us that drop in, like Rick and myself, and some of the other individuals, we're up there as organizers. We're not actually active surveillance organizers, but we are from the advanced group. I mean,
okay.
Unfortunately, we're the advanced guys, and Stuart. So we don't want to be in that class, but we are, unfortunately.
Well, given your 3+3 and no progression for 6 years, we're happy to have you here, but you don't need to be here talking about prospective treatment. You're in the best hands with the Wednesday night group.
Yeah, I mean, the reason is that there's a lot of anxiety in that active surveillance group, probably even more anxiety than there is in this group. Because the guys in this group, certainly if they've graduated this group, they've already sort of got their arms around it. Now, there is anxiety in situations like Tim's, but it's palpable in that AS group. And we don't want to exacerbate it by talking about treatments and sticking needles in your groin and surgery and all of that. So we try to keep those things separate. So even if you get more people with experience of treatment in the AS group, we don't talk about treatment because the guys don't want to hear it, you know, and they're all welcome, like you are, to come into this group, and you can go in there on Wednesday and say, oh, it was fascinating and I loved it and I like hearing of this, but you're going to hear things you might not want to hear.
Yeah. Absolutely. Yeah, you're right.
Okay. Well, we're happy to have you come back anytime.
Okay.
Did we miss anybody? Hands?
Not by my notes, but if anybody
No,
else
I
has
didn't, but I
something they
just want to
add,
make sure.
all came in late.
Paul, are you good? Okay, then. We thank everybody for coming and for hanging around, and we'll be back in 2 weeks, and we'd love to see you all, and have a good night.
Thank you. Great job.